So we're now starting on the placenta, which is the primary site of nutrient and gas exchange between mother and fetus. It has a fetal component and a maternal component. I like to see this diagram. It has this maternal component, decidua basalis, and it says that it is derived from endometrium and maternal blood in the leukemia. So this whole thing is the decidua basalis, and this is the lacuna, the space of reservoir of zealous, and there's maternal blood, which is coming through maternal artery and leaving through maternal vein from the residue of zealous. And then this is the fetal component. It has the cytotrophoblast and sensitotrophoblast, it says. So this layer is the cytotrophoblast, and this layer is the sensitotrophoblast, and this whole thing is called a branch villus. There is a fetal vein that carries the oxygenated blood, and a fetal artery that carries the oxygenated blood. And there is this amnion covering all of this placenta, and um, there is that's about it. So let's read it. Cytoplasm, it says, is the inner layer of chorionic villi. This is the amnion, and this is the chorion. This is the chorionic villus, and cytoplasm is the inner layer. Cytoplasm makes cells. Outer layer of chorionic villi is the sensitive trophoblast. It secretes human chorionic gonadotropin. Structurally similar to luteinizing hormone, stimulates corpus luteum to secrete progesterone during first trimester. It lacks MHC1 expression, which decreases the chance of attack by maternal immune system. Sensitive trophoblast does not have, it is the outer layer, right? So it does not have MHC1, and thus it cannot be attacked by maternal immune system. Then we have the umbilical cord. The umbilical cord has umbilical arteries that return. Oh, this image is kind of distorted. It is umbilical arteries that return the oxygenated blood from fetal internal iliac arteries to the placenta. The diagram is a bit shady. So yeah, it returns the oxygenated blood, fetal internal iliac to the placenta and umbilical vein, which is one in number, and it supplies oxygenated blood from placenta to fetus, and it drains into inferior vena cava via liver or via ductus venosus. Single umbilical artery to vessel cord is associated with congenital and chromosomal anomalies, and umbilical arteries and veins are derived from allantois. Let's see the umbilical cord. Umbilical. So, umbilical cord contains three blood vessels. Yep, that's right. Um, any image of it? I think it is. So it's umbilical cord. Diagrams of it. That's right. Stereo. So I'm thinking that these are the umbilical arteries and this is the umbilical vein, and that the umbilical arteries return the oxygenated blood from internal iliac arteries to placenta, and the umbilical vein supplies oxygenated blood from the placenta to the fetus. It's about it. Really wish these were clear. Next are the diverticulum. I think there's something missing there. Next is the vitelline duct. In the seventh week, there's obliteration of uterine duct, which is also known as inferior mesenteric duct, which connects yolk sac to midgut lumen. connects yolk sac to mid-gut lumen. With vitelline fistula is that vitelline duct fails to close and the meconium, there's meconium discharge from umbilicus. Sorry, you have to do clinicals and write. And Meckel's diverticulum is the partial closure of vitelline duct with patent portion attached to the ileum. True diverticulum may have heterotropic gastric and or pancreatic tissue, melena, hematochezia, and abdominal pain. Okay, so mainly the vitelline duct is obliterated during the 7th week, and here is the midgut lumen, and here is the yolk sac. If it fails to close, then there is a meconium discharge from the umbilicus, I suppose here, and if there is a partial closure between duct, then the patent portion is attached to ileum, which is a true diverticulum of the ileum, and it is called the Meckel's diverticulum, and it may have heterotropic gastric or pancreatic tissue. This diverticulum may have heterotropic, basically means from a different origin, right? So not from the ileum, but from the gastric, the stomach, the pancreatic tissue. This may have tissue, this diverticulum, and it can cause melena, hematochezia, and abdominal pain. And I have to see what hematochezia is. I haven't heard that word before. Hematochezia is the process of passing of bright red blood in the stools. All right. So melena is black stools, and that is red stools and abdominal pain. Okay. So now we come to aortic arch derivatives. This is the aortic arch, and we can see that this is the third aortic arch, this is the fourth aortic arch, this also forms part of fourth aortic arch, and this is the sixth part of the sixth aortic arch, and this is basically the structure of aortic arches 6 months postnatally. So they are saying that this portion has right recurrent laryngeal looped around here, and this has left recurrent laryngeal caught by the rectus arteriosus. Rectus arteriosus turns into ligamentum arteriosum shortly after birth of the larynx. Into ligamentum arteriosum shortly after birth. All right, let's study it. So the first arch forms part of the maxillary artery, which is the branch of the sternal carotid artery. First arch is maximal, so maxillary artery. Second forms is stapedial artery and hyoid artery. It's for S, stapedial S and hyoid artery. The third forms part of the aorta, and it forms the common carotid artery and proximal part of internal carotid. C is the third letter of alphabet, so common carotid and internal carotid. Fourth, on the left, forms the aortic arch, and on the right, proximal part of right subclavian artery. Fourth arch, four limbs, and it provides systemic supply. So here it is forming part of the aortic arch, the fourth artery, on the fourth aortic arch on the left, and on the right, it is forming part of the right subclavian artery there. And sixth is forming proximal part of pulmonary arteries, and on left only it is forming proximal part of pulmonary arteries. And on the rectus arteriosus, right? So the fifth was forming proximal part of pulmonary arteries on the left only, and also it was forming the rectus arteriosus, this thing. But the rectus arteriosus gets converted into ligamentum arteriosum shortly after birth. Sixth arch is equal to pulmonary and the pulmonary to systemic shunt, which is ductus arteriosus, right? So ductus arteriosus is basically the pulmonary to systemic shunt. And left recurrent laryngeal nerve gets caught here by the ductus arteriosus at this point. below the sixth arch or fourth arch, or the part formed by them. And right recurrent laryngeal are nerve loops around the subclavian artery. Next, we have the branchial apparatus. This is the primitive pharynx, and these are the pharyngeal arches, the first, second, third, fourth, and between the arches on the external side, there is a cleft, and on the internal side, there is a pouch. And then there is the primitive esophagus built down the primitive pharynx, and it is surrounded by epicardial ridges. So they say the branchial apparatus is also called pharyngeal apparatus, composed of branchial clefts, arches, and pouches. So clefts, arches, and pouches, these three. Branchial clefts are derived from the ectoderm. So, okay, first thing we said is that the clefts, the external portion is determined from the ectoderm, also called branchial grooves. And now we might change the color. Branchial arches, the middle portion sort of, is derived from the mesoderm, muscles and arteries, and neural crest, bones and cartilages. And branchial pouches are derived from the enoderm, the inner portion from the enoderm. Cap covers outside to inside. Clefts, ectoderm, arches, mesoderm, and pouches, enoderm. Okay. So branchial cleft derivatives. First cleft develops into external auditory meatus. So this portion develops into external auditory meatus. Second to fourth clefts form temporary cervical sinuses, which are obliterated by proliferation of second arch mesenchyme. Persistent cervical sinus is the branchial cleft cyst with lateral neck. Right. So first form external auditory meatus, and second to fourth form temporary cervical sinuses, which are obliterated, and if they persist, they can cause branchial cleft cysts within lateral neck. Right. And branchial arch derivatives. The first arch forms Meckel cartilage, mandible, malleus, incus, sphenomandibular ligament. They don't have a diagram for it, right? Wait. So this seems like a good diagram. This one. Okay. So this is the first branchial arch, and here it's developing the nerves of thalamic nerve from trigeminal nerve, maxillary nerve from trigeminal nerve, um, cartilage, the Meckel's cartilage, the sphenomandibular ligament, anterior belly of digastric, masseter muscle, mandibular nerve from trigeminal nerves. So basically, all three of trigeminal nerves branches it's forming fifth nerve. And it is also forming the bones incus and malleus. This is the second arch, and it forms stapes, the remaining bone of the ear. And for the nerves, as we did trigeminal there first, I think it forms facial nerve from geniculate nerve. Facial nerve is the main nerve for the second pharyngeal arch, and it forms the posterior belly of digastric. First form the interior belly of digastric, and this one forms the posterior belly of digastric. There's also the lesser horn of hyoid bone, styloid ligament here. There's a lot of S in the second pharyngeal arch. And there is lesser horn of hyoid bone, auricular anterior muscle, auricular superior, basically facial muscles, muscles of facial expression, or mimetic muscles. And then this is the third branchial arch, and it forms glossopharyngeal nerve, stylopharyngeus muscle, and greater horn of hyoid bone. Pretty simple. And then there's fourth and fifth branchial arches. They form the pharyngeal muscles. The fifth arch actually gets obliterated, and it's the sixth one that we have to memorize. So it forms the laryngeal nerve from the vagus nerve, the cricoid cartilage right here, and the pharyngeal muscles and thyroid cartilage. So um, let's now again here. The first arch forms mectal cartilage. We've seen that one. Mandible, we've seen that one. Malleus, we've seen it. And sphenomandibular ligament, we've seen that one as well. Muscles of mastication, which involve the temporalis, masseter, lateral medial pterygoid, mylohyoid, interior belly of digastric. We've seen that one. Tensor tympani and tensor villi palatini, we've not seen those. So these are new. And it forms cranial nerve V2 and V3. So they've written only two of them, and it is used for chewing. And the abnormality is called Treacher-Collins syndrome. This is important. Treacher-Collins syndrome is the first arch neural crest fails to migrate, and there is mandibular hyperplasia and facial abnormalities. Let's search Treacher-Collins syndrome. All right. So there's mandibular hypoplasia and facial anomalies. Mandibular hypoplasia and facial abnormalities. Right. And then we have the second arch, which forms the Reichert cartilage, which is the styloid process. So stapes and styloid process are mainly bones that it forms. Just a horn of hyoid is a bone that it forms. I think stylohyoid ligament and Reichert cartilage would be the cartilage here. And muscles of facial expression involving stapedius, stylohyoid, and platysma, with the emphasis on S, and posterior belly of digastric. Cranial nerve 7, which is the facial nerve for smiling, and it causes congenital pharyngocutaneous fistula. Persistent of cleft and pouch fistula between tonsillar area and lateral neck. So let's search which congenital pharyngocutaneous fistula is like. Congenital pharyngocutaneous fistula, yeah, that. So it is, this one seems apt. Communication of digestive tract with the cervical skin, which originates the appearance of saliva on skin after swallowing at the level of surgical incision around the tracheostoma. So there's continuous flow of, it is the persistence of the second cleft and pouch and the fistula between tonsillar area and lateral neck. So the tonsillar area in the mouth and the lateral neck, and there's continuous saliva through it. Right. So the third arch has a cartilage of the great horn of hyoid. The nerves are cranial nerve number 9, stylopharyngeus, swallow stylishly. Okay, so it's associated with swallowing and stylish. Stylopharyngeus, think of stylopharyngeus innervated by glossopharyngeal nerve. So yeah, basically, number 9 is glossopharyngeal, and it supplies stylopharyngeus for correction. Fourth and sixth arches have cartilages of thyroid, cricoid, erythroids, corniculate, and cuneiform. The fourth arch are mostly pharyngeal constrictors, cricothyroid, and levator villi palatini muscle suppliers. All right, so levator villi palatini was also supplied with the first arch. No, sorry, that was tensor villi palatini, and this is levator villi palatini. So it's Leviosa. Okay, levator villi palatini by the fourth pharyngeal arch, cricothyroid, and the pharyngeal constrictors. And the sixth arch applies all intrinsic muscles of larynx except cricothyroid. And bootcamp said cricothyroid was really important because the step likes to test exceptions. So larynx has 6 letters, sixth arch, all intrinsic muscles of larynx except cricothyroid. And fourth arch, most pharyngeal constrictors, cricothyroid, which is a laryngeal muscle, not supplied by the sixth arch and levator villi palatini. So the fourth arch supplies cranial nerve number 10, superior laryngeal branch of the vagus, and the sixth arch has the vagus recurrent laryngeal branch. Arches 3 and 4 form posterior 1/3 of the tongue. Arch 5 makes no major developmental contributions, right? So this one's important, that arch 3 and 4 form posterior 1/3 of the tongue. For These nerves, they've said that they're only cranial nerves with both motor and sensory components, except V2, which is sensory only, right? All of these have both motor and sensory components except V2, which is only sensory. And when at restaurants of golden arches, children tend to first chew, then smile, then swallow stylishly, or simply swallow and then speak. So this is a good way to remember it if you want to. Then there's wrinkle pouch derivatives. There were four pouches in there, and the first pouch has to do everything with the ear. So it develops into middle ear cavity, eustachian tube, and mastoid ear cells. First pouch contributes to endoderm-like structures of ear. Second pouch develops into epithelial lining of palatine tonsil, and third pouch has a dorsal wing and a ventral wing. These two are important. Dorsal wing develops into inferior parathyroids, and dorsal wing of fourth pouch develops into superior parathyroids, and ventral wing develops into thymus. Third pouch contributes to three structures: thymus, left, and inferior parathyroids. Left, right, and inferior parathyroids. Third pouch structures end up below fourth pouch structures. So ear tonsils bottom to top. First forms ear, second forms tonsil, third dorsal forms bottom for inferior parathyroids. Ventral, there's a teen ventral, so thymus and top superior parathyroids. Bottom to top, right? So superior thyroids end up above inferior parathyroids, which are formed by the third pouch. Now, Diegers's syndrome. It is an aberrant development of third and fourth pouches, T cell deficiency, which causes thymic aplasia and hypocalcemia, failure of parathyroid development, associated cardiac defects, chronotruncal anomalies, and then there's MEN2A, mutation of germline RET, neural quest cells. There's adrenal medulla, pheochromocytoma, parathyroid, third to fourth pharyngeal pouch, parafollicular cells, and middle with thyroid cancer derived from